Welcome, everybody. It's Sahil Parikh from Columbia University, New York, and it's really great to be here with you today to talk about a manuscript that'll be published in JSCAI. We're going to talk with the authors of this manuscript, Dr. Khalid Changal and Raj Gupta from University of Toledo in Ohio. They've put together an updated meta-analysis on an evergreen topic, the use of drug-eluting stents versus conventional endovascular therapies in symptomatic infrapopliteal PAD patients. We have a terrific panel today. We have Sasanka, Jayasuriya, June Lee, and Mac Ansari, all very busy peripheral interventionalists who are interventional cardiologists and have a lot of experience using these technologies below the knee. And so without further ado, Khalid, why don't you go ahead and take us through the manuscript, and then we'll have some time to talk about it.
Okay, thank you, Dr. Parikh. So I'm going to start. I have a brief presentation. So as you know, the title of our presentation is Drug-Eluting Stents versus Conventional Endovascular Therapies in Symptomatic Infrapopliteal Peripheral Arterial Disease. And this is a meta-analysis of randomized trials. We do not have any disclosures. So the question one might ask is, why is a meta-analysis needed? Balloon angioplasty with bailout stenting has been standard endovascular therapy for many years for symptomatic infrapopliteal lesions. However, balloon angioplasty is complicated by dissection, restenosis, early or late vessel occlusion, and possible recurrent symptoms requiring further revascularized procedures or leading to adverse outcomes. Infrapopliteal arteries are similar in diameter to coronary arteries and can be treated with coronary drug-eluting stents. Individual trials comparing DES with endovascular therapies have shown variable results, mainly due to a smaller sample size. These individual studies were not powered to detect clinically meaningful outcomes. Thus, we feel that a meta-analysis would add to this topic. So why could DES infrapopliteal arteries treat PAD better? The current iteration in design of coronary DES provides unique benefits for treating infrapopliteal lesions, such as thin strut design, low thrombogenicity, and easy deliverability. DES provides strong radial force to counter recoil, and local delivery of anti-proliferative drugs prevents neointimal proliferation and restenosis. Balloon angioplasty of infrapopliteal lesions is often limited by elastic recoil in short term and restenosis in medium to long term. Bare metal stents also have limitations such as restenosis. So methods, briefly, we use standard methods for performing systematic review and meta-analysis. On one arm, we had a use of drug-eluting stents uniformly in the experimental arm, and in the control arm we have standard endovascular therapies which involved balloon angioplasty with or without bare metal stenting. And we use pooled hazard ratios to calculate effect sizes. After undergoing thorough literature review and going through various studies, we were able to pick up 9 randomized controlled trials in this study, and the earliest one was from 2007 going forward. So to briefly give the results, this study included 9 trials enrolling 945 patients, 463 in the DES arm and 482 in the control group. And majority were followed for 12 months or longer. The mean age of patients ranged from 68 to 75 years. Majority were men, and majority of patients had comorbidities like diabetes, hypertension, hyperlipidemia, and smoking. The primary outcome we studied was primary patency. When we compared drug-eluting stents with the control arm and pooled their results together, we found that the drug-eluting stents had much better primary patency. The statistical significance was seen for this outcome. The total hazard ratio of 2.17 significantly favoring drug-eluting stents. We did subgroup analysis for patients with critical limb ischemia and found significant results favoring drug-eluting stents for that arm as well, with a hazard ratio of 2.5. When studying target lesion revascularization, we again found drug-eluting stents were better than the control arm with a hazard ratio of 0.48, significantly favoring drug-eluting stents. And we performed subgroup analysis for critical limb ischemia patients and found similar results with a hazard ratio of 0.44, favoring drug-eluting stents. When comparing the other outcomes like all-cause mortality, we did not see any significant difference between drug-eluting stents and controls for this outcome. Similarly, we also did not see any significant difference for major amputations between drug-eluting stents and control arm. This result was not statistically significant. However, numerically, it favored drug-eluting stents. So to sum up, we compared drug-eluting stents with conventional endovascular therapy, and we found that overall drug-eluting stents had better primary patency, better target lesion revascularization, and a similar all-cause mortality and amputation rates. Thank you for your patient hearing. And I end my discussion here with this question: that is a time for a paradigm shift to consider drug-eluting stents as a primary mode of mortality for infrapopliteal peripheral arterial disease. So I will open this up for discussion. Thank you.
Thank you very much for your presentation and for the opportunity to discuss the paper. Dr. Gupta, as the senior author, what motivated you to sort of command these trainees of yours to put this together? What was the motivation?
Well, I'll give a lot of credit to Khalid that he came to me with questions and we discussed, and that's how the project was born. But in my practice, I would say, we, as someone who's a coronary interventional operator and a peripheral operator and deals with a fair amount of BTK, below the knee lesions, you're just struck by how similar the arteries are, and you wonder, if you do an LAD, atherectomy, and angioplasty, and you have a pretty good result, 100% of the time, you're gonna put a drug-eluting stent in there because there's certain benefits or outcomes that are known to be improved, regardless of the angioplasty result. In BTK, it's a different world. I would say most operators are doing stenting as a bailout procedure. If they have major dissections, if they have reduced flow, if they're concerned about an inadequate angioplasty result. So it really raises the question, is our practice evidence-based, or is it kind of stylistically based or experientially based, that in the past, angioplasty was the only modality, and in the current era, there's so many different modalities. It raises the question, what is the evidence base for dealing with infrapopliteal lesions?
That's a great segue. So June, you and I have worked together for many years, and you've got some experience understanding the drug delivery principles. Is the TLR rate of a drug-eluting stent below the knee the same as the TLR rate of a drug-eluting stent in the LAD, to use Dr. Gupta's analogy, or are they different?
Thanks, Sahil, for the question, and congratulations to both of you for this excellent paper. So certainly, when we look at LAD PCI versus below knee interventions, the below knee interventions tend to have longer lesions. The diameters might be similar, but the lesions we're dealing with are 150 millimeters, 250 millimeters long. So in terms of longevity of stents, drug-eluting stents in the legs, they're a lot shorter compared to LAD PCI, just purely because of the lesion length. I think that is going to be a major factor in terms of applicability of drug-eluting stent across the board for all CLI patients. Part of the reason why we're hesitant about doing scaffolds below the knee is because of this reason. Whether or not that will lead to long-term outcomes that remain beneficial, I think truly we need to do a dedicated study for below the knee CLI patients, especially if you're looking at the distal 1/3 of the vessels in the leg, right? So a lot of tension, a lot of tortuosity can occur in that area. So I think there's a lot of unknowns right now in the lower extremity, below the knee scaffold use. So I think more needs to be done in terms of studies.
Yeah, so it's always easier to ask for more data, but in the absence of that, we have to practice in the real world and make decisions. So Mac, you are a busy CLI operator, and I think infrapopliteal intervention is synonymous with CLI. How often are you using coronary DES in your current practice? And do you think that these data will help you support that? Or what would it take for you to use it more? Or if you had to draw it up differently, what would be a better alternative?
No, first of all, thanks, Sahil, for this invitation, and congrats on a really good paper. And in my practice, it's really funny. Today morning, I had my vascular surgeon coming upstairs to the cath lab and going to the stent room, picking up stents for his patients today, And then he calls me and he says, Mac, I'm looking for rapid exchange 25 by 38 stent. Can you please help me locate those, you know? So it was very interesting. And I was talking to him about it because the below the knee is a different animal. It's a different anatomy. The vessels are different texture. And we have seen that just balloon angioplasty doesn't help. And it comes to a point where in order to secure flow, you have to put in a stent. So 20 to 25%, and now it's even increasing. We have seen more disease, more calcified lesions. Even after atherectomies, it comes to a point that you end up leaving, particularly for the proximal part of the vessel. And if you secure the proximal part, the vessel flow just streamlines. There's also challenges in the distal part near the ankle because they don't remain open and you see fractures over there. So this is what we see, but it comes a point just balloon doesn't help. So we're seeing more and more. And yes, this paper really helps because there was one very interesting thing in this paper that I was looking at, that it's not statistically significant about the amputation difference, but the trend really shows. And the trend is enough. If I can get a trend that shows me, because these patients, this disease, CLI is a deadly disease. These patients are sick, they have many comorbidities. And if I can see a trend from patient to patient difference, making it a difference on extending or preventing amputation, then I'll take it. If you look at the study, the amount of patients and the amount of studies, and talking about primary patency, that's really good result. I understand there was not a difference in all-cause mortality, but it was similar. It was not on the other direction. So it is a really good results that point out towards a therapy that we can help our patients, because if you look really out there, balloon angioplasty, what it has led us to, we are still figuring out what to do. So it just gives us another option to look into.
So Sasanka, you likewise use these devices in your clinical practice every day. What's your percentage of use of these currently, and what do you think it should be?
So my use, as well as Khalid had mentioned, is fairly low. It's for bailout or lesions that are not yielding. But this paper is really eye-opening. So congratulations to Khalid and Raj on a well-done paper. And you know, if we can improve the patency, it will, with time, with larger numbers in studies, it will improve mortality and amputation. And with CLI patients, they are so sick that anything helps. You know, a trend is we will take that because our patients are really struggling. The downside to it is the cost, right? Without knowing exactly what, exactly that there is a definitive benefit in it, I'm not sure if we are still willing to go ahead with this, face this cost, because as Dr. Lee mentioned, these are long lesions. You need 3-4 long DES for each tibial vessel. So there are benefits and disadvantages, but I would certainly be more in favor of placing DES below knee after listening to your presentation today.
Well, I'm going to take the editorial prerogative and make a few comments. First, the TLR rates of the same stent, whether it's in a coronary or in the below knee segment, are different. The late loss of a everolimus-eluting stent that's used in a coronary is usually under 0.2 millimeters. In the below knee segment, in a similar population, including diabetics, is about 4 times that, more like 0.8. So if you don't have a big diameter vessel, you are likely going to get a TLR with a drug-eluting stent below the knee. And that's not because it doesn't work. It's just because it works differently, probably because the biology of those two vascular beds is different. Nevertheless, we are habitually undersizing below knee arteries. I think that we've all learned with the use of IVUS that that 2538 Mac that your surgeon borrowed was probably way undersized.
Yeah,
and
absolutely.
I really hope they know how to post-dilate a coronary stent. You can get a 2.5 to 3.5 pretty easily. But I think that certainly the biology is different, but if deployed properly, they can be very effective. You know, Mac mentioned something and June mentioned something, that it's the proximal third where we feel like these are the best utilized. We now have an FDA-approved self-expanding bare scaffold for below the knee as well. And we have a number of drug-eluting technologies, both bioresorbable and self-expanding drug-eluting in clinical trials, which we're waiting with bated breath to see those results. So I think if you were to sort of draw it up in the big blue sky, Raj, what technology would you hope, in addition to drug-eluting stents, will be next available for these CLI patients?
Yeah, great question. Let me back up and focus on this. So in the current era, I just reviewed prior to this talk that about 70 to 80% are treated with angioplasty alone. That was on VQI or Vascular Quality Initiative data. And the primary patency is about 50% in a good data set at 6 months. So I think clearly we want to do better. If we're doing this kind of work and some of these cases are difficult, you're spending 2 hours, 3 hours, you're doing antegrade, retrograde, you're doing a lot of work, we want to do better. I actually think the coronary drug-eluting stent is a fairly good technology, especially in the proximal 1/3. You're shielded from external compression because of the bony anatomy, the fibia, tibia and fibula. And as far as the length consideration, I kind of break the artery up into kind of thirds, like proximal, middle, and distal. And the mid to distal, I'm going to favor a balloon angioplasty approach. Maybe in the future there'll be data for DCB. Potentially, there's a solution like TAC if you have focal dissections. And then maybe there's room for innovation as far as a bioresorbable scaffold in the future. I'm not sure if that would have the mechanical and properties and drug delivery properties that would make it a game changer. And then the wild card we didn't talk too much about because these data sets don't include much about atherectomy, but I know a lot of people in their practice have been adopting more and more atherectomy strategies in below the knee calcified disease. And it is difficult to organize these trials, like these investigations, when you have one arm being atherectomy with balloon angioplasty, one arm being atherectomy with a stent technology or a scaffolding technology, and so on. So I guess that's my roundabout answer. Is it any does that help, or what do you think?
Well, it's clear as mud. I think that, but well answered. So I'll ask for a one-word answer from our panel. What's the technology you want most for the below knee segment? Sasanka, what's the one technology? DCB. June?
I agree. DCB, that works well for below the knee.
And Mac?
Scaffold.
Mac's a scaffold guy. Well, so I think what's clear is that there's a lot of heterogeneity in the patient population, in their disease anatomy, and in the treatment options we have. None of them has yet bubbled to the top as being the preferred or preferential strategy because the absence of clinical data. And what's really helpful is to have it distilled down like you guys did, Khalid and Raj, to show the population of patients who benefit from the use of these devices. So we certainly appreciate your contribution. We look forward to everybody out there picking up this edition of JSCAI electronically and clicking on the links to read this paper. And we hope that this editorial commentary will help put into clinical context how we might apply these data to our everyday practices. So for now, I want to thank everybody for your time, and we welcome your comments both online and via email. And again, we look forward to seeing you on SCAI.org. Thanks very much, everybody.
Thank you.
Thank you. Thank you very much.